Hai, kenapa lambat ni? Hah? Betul webinar. Kan? Masa tak boleh masuk. Try joining again. Ah, I'm in the webinar. Mana? Oh, okay. Ya, berapa dah 63? Okay. So, dah ada banyak dia. One more minute eh. Just Hi and welcome again, everybody. Thanks for joining in. Let me introduce our next speaker, Dr. Fazlin Haslinda Muhammad Hatta, Senior Lecturer from UiTM Puncak Alam, Shah Alam. Dr. Fazlin obtained her PhD in the field of medical sciences from Karolinska Institutet, Stockholm, Sweden in 2015, after spending an industrial training in Karolinska University Hospital, when she was a recipient of international fellowship and postdoctoral grant from KPT. Prior to that, she was a research student in the field of pharmacogenetics in UiTM. Her research interests evolved from genetics of addiction to pharmacogenetics, especially in the realm of personalized medicine, drug metabolism, biotechnology, and gene editing. As usual, please type in your question for Dr. Fazlin in the Q&A box before. She'll be available online to answer. The topic of our presentation today is personalized medicine as a new healthcare. Without further ado, let's welcome Dr. Fazlin Haslinda.
Assalamualaikum and salam sejahtera. Thank you to the chairperson, respected guests, and I hope everyone is doing good today. First of all, I would like to thank you, the Malaysian Association of Clinical Biochemists, MACB, for inviting me today to speak about a topic that, as a geneticist, I am very, very passionate about. So, the title that was given to me is Personalized Medicine as a New Healthcare. I tried to negotiate a little with Madam Susanna about tweaking it just a little. Stick to it, she said. So, okay, personalized medicine as a new healthcare, it is. But this is such an important title. Personalized medicine, or sometimes referred to as precision medicine, maybe is the biggest revolution in the field of medicine we have seen in a very long time. So today we will talk a little about how personalized medicine is driving healthcare into the future, hence the term new healthcare. So in the next slides, or rather in the next half an hour maybe, We will look into what is personalized medicine, what is the current practice that we have right now in terms of medicine, and what is new, what is upcoming, um, how does it work in general, and also what is the role of biochemists in personal medicine. Well, I have to say that it's a very central role, and I think all of you know that. What are the biomarkers? Because these are the very important ingredient to a personalized medicine, and also the current state of knowledge and what are the technology that we're using today. Uh, we're gonna also look into examples of personalized medicine that are being practiced today, and of course we're gonna look also into the current issues that we face and a little bit about what's in the future for us. So for the benefit of the audience, I'm gonna switch off the camera for the rest of the talk so that you can focus on the slides here. Now, let's get acquainted with the word personalized medicine. So it is a fairly broad topic, but in an essence, we're talking about using someone's biological profile, be it genetic or any other biomarker information. It can range from blood pressure to a reading of certain protein from the serum of a patient, for example, to make treatment decision about said patient. So the highlight here is that using an individual's biological profile to guide decisions made in regard to how they are going to receive their treatment. So I will try to explain that in this picture that we have here. Current treatment that we have today adopted the one treatment fits all method, where we give the same treatment that works on most people to everyone. That means we will see a big group of people who responds well with the treatment that was given. So these are the group of people who will get positive effect from the treatment that we give. But there will also be a group of people who will get no effect from the treatment. So there's also a significantly big group of people who do not gain any benefit from the treatment that was given to them. And then there's another group of people who will suffer from adverse reaction. So adverse reaction are bad side effect of a treatment. It could be mild, like nausea or diarrhea, or it could be severe that could also lead to death. Now, for these two groups here, they will need to come back to the hospital or clinic to get their therapy adjusted. It takes time from the healthcare workers and also from the patient to get the treatment. And sometimes these treatments are urgent, so they need to immediately adjust the treatment that was given to them. Otherwise, it will be life or death. And sometimes this situation also incurred cost to the clinic as well. So in the future, in the ideal future that is, we want a more personalized medicine. Think of it as buying clothes off the rack at H&M or going to a tailor and have your clothes made specially for you or from your own measurement. So of course you will be more comfortable in a clothes that is made to fit your body, right? So thanks to the advancement of science and technology, we are able to screen for genetic markers, metabolites, proteins, and even drug metabolites in a short period of time. These specimens can be obtained from blood, from serum, from urine, and from tissue samples of a patient. We will then add in our factors, other factors such as lifestyle, age, other medication data, and combining this information can lead us to a decision. And of and the decision would be what is the best therapy, what is the best dosage to achieve the maximum benefit from any treatment. And the best case scenario is that everybody benefits from the therapy, with no group left with side effects or no treatment at all. Treatment decision can include decisions about who gets certain kind of therapy or specific dosage of a given therapy, or who should be monitored more carefully because they are predisposed to a particular safety issue. We can group patients into groups based on their biology indicators. Here is an example. If you fall into a group of drug responders, then great. Normal route of treatments works for you. But if you fall into the poor prognosis group, your doctor can change the regimen, give you an alternative treatment that will work on your case. Same goes to the high risk group of side effects. So a change of an alternative medication can save your life. And these data can be used for the future as well. In case you are known to carry any biomarkers that indicates you cannot take a medication, if proper health record is stored, then the doctor will know and will make the proper decisions for you. Sometimes these biomarkers can also predict if you have a higher chance of getting a certain disease. So proper lifestyle change or intervention can be made in these instances to avoid you from falling ill of said disease. So personalized medicine isn't just about prescribing the drugs, it's also about improving diagnostic, predicting the likelihood of someone developing a condition, and stopping a condition from getting worse. So the ultimate goal of personalized medicine is number one is to give correct treatment or correct medication to patient. Number two, to predict a safer dosage and avoid anyone from getting adverse reaction from the treatment. And number three is to know who to monitor in cases of uh, people who are at risk of serious side effect or people who are at risk of developing a certain kind of disease.
Like I've mentioned before, the move from one size fits all medicine to the more case-based, more personalized medicine is made possible with the advancement of modern biology. And in my second slide, I did mention the role of clinical biochemists in driving personalized medicine in the future. So congratulations, you do play a key central role in the large scheme of it all. So from processing the specimen to the molecular analysis to the data collection to the biomarker identification, that's all you. And I hope you're okay with that, such big responsibility on your shoulder. But of course, clinical biochemists and clinical medicine are codependent components of the medical system. Laboratory medicine function most efficiently when focused through a clinical ecosystem. What I'm trying to say is that without clinical biochemists, uh, the the move from current medical system to the new, more personalized medicine is not possible. Being in the medical field, we all know that it is a very dynamic environment. So we always encounter new drugs, some new treatments, and then there's always changes in management strategies when it comes to trying to treat patients with certain diseases. So we also encounter new techniques, new technology, new tests on the other hand, that keeps expanding and we keep having to learn new things. And these changes, they require dialogues and interaction and sharing sessions between the clinical and the laboratory medicine specialists. So when we talk about the role of clinical biochemists in the new healthcare ecosystem, then we need to understand that subsequent investigation, including laboratory testing, can act to refine the diagnostic hypothesis towards a better treatment or a better management plan. So it has been shown that laboratory testing directly affects 70% of the clinical decisions. So that's a very huge roles we play in the healthcare ecosystem already right now. And in the future, this role will probably increase rather than decrease. So to achieve the most ideal environment of personalized medicine, it is key for laboratory practitioners to understand what we do. And this includes not just the clinical condition being investigated, but also the process of patient flow. What's going to happen with them? What's next for them? Not just like the test that we're doing currently, but what's next for them. Then we know what to look for basically in the lab setting. And we should be very skillful in the laboratory, but also outward facing, meaning that we don't just focus on our techniques, but also improve our knowledge in what's going on in the world of medicine, for example. And we also need to understand the strengths and weaknesses of certain testing and also know how this fits into the decision-making process. If there's another test that is better that you can suggest, then maybe it's time for clinical biochemist, to take a role in giving advice or giving suggestions to the clinician of what tests should be done on the patient. So I think everybody knows what a biomarker is. I'm 100% confident of that. But for the sake of being on the same page, so maybe I should put on what the definition of biomarker is when I talk about biomarker in this talk. So the short definition of a biomarker is that it is anything that can be used as an indicator of a particular disease state. So biomarkers are characteristics of the body that you can measure. For example, your blood pressure, that's a biomarker. What about the long answer? So biomarkers are molecules found in the body fluid, or tissue. So research sometimes shows that people with a certain biomarker are more likely to respond to treatment than those who do not have the biomarker. So doctor can test for the biomarker before starting any treatment. That way, patients who are most likely to improve are the ones given the treatment. The terms genetics, pharmacogenetics, personalized medicine, and pharmacogenomics have been used interchangeably to mean the study of genetic variation and their influence on the way people respond to medication. And those are an example of a molecular biomarker. Examples of molecular biomarkers are DNA, antibodies, proteins, and other small molecules that we can extract from the body of a patient. Whereas an imaging biomarkers are biomarkers that we can see with the naked eye, like a tumor that shows up on an X-ray of someone's lung. So by looking at either the presence or the absence level of one or more or a combination of biomarkers, a doctor can diagnose a patient with a disease and find out which treatment is the best for them. So does your body have high levels of glucose? So if this exists and combined with some other symptoms, we may indicate that this patient have a type 2 diabetes. Usually, the biomarkers are used in three ways. The first one being a prognostic biomarker, where we can predict how likely some event is going to occur in the future. So using this prognostic biomarker, we know that you're gonna get some kind of disease, or are you going to be at risk of a certain type of illness due to your lifestyle or the treatment that you're having, or the kind of exposure that you're having. The second one is the predictive biomarker. So this can indicate which treatment will be most effective for a disease. So you will, based on your biomarker, we will know that this treatment works for you or this treatment do not work for you. So, but another treatment might work, for example. And the third one is the pharmacodynamic biomarker, and this indicates whether a treatment is causing a response. So the response might be showing that the treatment is working, or it could be a sign that a side effect is going to happen, so stop the treatment. An example would be when someone goes to a clinic with diabetes, for example. The doctor gave instruction, have low carb diet for a month and come back. So when the patient come back and some tests are done, so the doctor will see the biomarkers and he will say something like, okay, predictive biomarker indicates that this low carb diet works really well for you now that you've been on that diet. And I can see from your pharmacodynamic biomarker that the diabetes is so much under control, it's so much better, and you should keep up with the diet. So the pharmacodynamic biomarker indicates that the low carb diet should be continued. So after testing the DNA, the doctor will say like the prognostic biomarker indicates that you might actually have a high risk of a heart disease. So I would like to put you on an exercise regimen on top of your low carb diet, something like that. While some personalized medicine are only attainable via laboratory work, we sometimes forget that personalized medicine can also come in the form of devices that helps with our everyday life. For example, I'm sure everybody here wears healthcare wearables, such as the fitness trackers that can track one's fitness level in terms of several vital signs and daily physical activity. Some advanced fitness trackers are called biometric smartwatches, and these are especially good for people who have heart condition, diabetes, hypertension, leukemia, chronic infectious illness, and other diseases in which sleep and blood parameters are affected. So these watches are able to send messages to caretakers and healthcare providers at the moment an abnormality is detected. And this is proven to be of big value for people who suffer from heart attack or strokes or some other types of abnormality. And some of these smartwatches even come with electrocardiogram or ECG monitors. Another one would be the epileptic detectors that takes measures of the heart rate and skin conductive variability. And these devices are able to predict with a high degree of accuracy when someone is about to suffer from an epileptic seizure. So this is the category that most of you are probably very well versed in the diagnostic tools. So besides the regular laboratory-based testing, there's some new advancements in terms of diagnostic tools. For example, biosensor are the next in line innovations after smartwatches, which is taking on the form of self-adhesive patches. So it's a step up from wearables, but these patches perform many of the same function that a wearable can do. And it has an added feature of measuring one's respiratory rate, temperature, and also movement. Another one would be the nanoparticle, and these particles can easily be taken up by cells and can penetrate many nanoscopic structures in cell, including the DNA and also the RNA. So each particle gives out a unique signal, and the property of which can be measured and cataloged in accordance with different biologic media in the house that is inserted with the nanoparticles. So in this way, unique reading can be collected and used to accurately assess biomarkers specific to different type of diseases. This one is something that I'm very excited about, an improved gene sequencing. Although gene sequencing have been around for a while, but it has massively increased in its sophistication at picking up genetic biomarkers and improving their accuracy as diagnostic tools. So this is particularly important for diseases with an epigenetic component, where the gene pertaining to one type of illness may express a large degree of variability among individuals. So an example of that would be autism, cancer, and some complex autoimmune diseases that have, and also multiple sclerosis. So in these conditions, hundreds and thousands of different genetic configuration may pertain to some diagnostic. So there's many different types of genetic sequences that can cause these diseases, and the combination of this genetic configuration can be done these days in a very short time and in a very low cost, and this makes precision medicine an absolute tool and a game changer for personalized medicine. Besides the monitoring part and the biodiagnostic part of personalized medicine, there's also the move to enhance precision medical treatments. And to help with that, we have now the artificial intelligence that has begun to play a major role in determining the best course of action with whatever available data that we have on a patient. So this include real-time feedback from the patient, biomarker results from previous treatment and the current treatment, and also the latest information that we get from research. So in combination of that with practical experiences of doctors or physicians, patients will be able to receive the best possible treatment plan there is. And it is tailored entirely to their unique biological requirements and their lifestyle. Scientists have also been working on creating an improved delivery system to overcome the problem where drugs are not 100% using its 100% potential to treat a patient. These are probably due to the fact that the drug probably have a reduced effectiveness once it is metabolized in the body, but we are seeing improvement day by day in the terms of drug delivery part of medical treatment as well. Let's have a look at an example of personalized medicine in the case of warfarin. So warfarin is an anticoagulant drug that is quite difficult because it has a wide variation in dose required for different people to achieve therapeutic effect. So the dose needs to be adjusted in a lot of people because um, in order to reach the therapeutic effect and not get side effect of serious bleeding in individuals. So warfarin act as interfering with the cycling of vitamin K in the liver. That vitamin K is related to blood clotting factors. So usually people take warfarin after transplant or surgeries, heart surgeries, for example, in order to avoid from having blood clots. So it interferes with the recycling of vitamin K so that blood clot do not happen. So it's also known as a blood thinning drug. So the most important gene that we know that affects warfarin would be cytochrome P450 2C9 here and VCORC1. So these are two main genes that are involved in the processing of warfarin in the body. I have to say that there's actually more than these two genes that are involved with the metabolism and bioavailability of warfarin, but these two are the most important ones. So these two genes, together with environmental factors, would partly explain the differences in different people having different dose requirement for warfarin. This is because people who are, for example, CYP2C9 star 2 that carries this gene in their body, and people who carry this type of gene in their body would need a longer time for the dose to stabilize, and they are at risk of serious to life-threatening bleeding due to their incapability of throwing warfarin out of the system. Basically, the warfarin would accumulate in the body and not be able to be secreted out from the system. And VCORC1 or VKORC1 have mutations that influence time to first therapeutic warfarin range, and it determines low, intermediate, or high warfarin dose requirement, meaning that you need different dosage of warfarin according to the mutation of VCORC1 gene that you have to be able to get the drug to work. So it's a little bit complicated, but with a lot of research and studies, scientists are able to come up with an algorithm that can calculate um, based on your age, your height, your creatinine level, and other factors, including your gene situation, whether you carry certain mutation in VCORC1 or certain mutation in CYP2C9. We will be able to kind of calculate the initial dose that you need, the safe dose that you need to take warfarin. So another case is the case about the cystic fibrosis treatment. So this is an example of personalized medicine in cystic fibrosis. So basically here we have an inherited disorder that make people sick by disrupting the normal function of the epithelial cells. So people who have cystic fibrosis are at risk for getting repeated lung infection. So the disease is diagnosed by sweat test and CFTR mutation screening. So in a population here, we have people who are suspected of cystic fibrosis. So what we do is we do sweat test to check in the content of chloride in the sweat. So people who have a higher number of chloride in the sweat are suspected to have cystic fibrosis, and the one that have a lower number of chloride in the sweat are considered as non-CF patient or non-cystic fibrosis patient. So these days, in some research facility or research hospital, people can go for CFTR gene screening. So this is the one that you see here are the mutation that are happening in the gene, the CFTR gene, and the location of mutation corresponds to where it points out here. One mutation that is known as the F508 deletion is known as the main CFTR mutation that affect most patients with cystic fibrosis. So here is the molecular diagram of what the CFTR gene does to individuals with cystic fibrosis. So here you can see the normal functioning of something that we call wild type CFTR gene that produces a normal functioning protein. So, and then figure number 1 till figure number 6 are what happened when there is a disruption in the process of producing the CFTR. Some people would have a defective protein and some people would have a reduced protein, meaning the protein is normal, but there's some in like something that stops the protein from being sent to the right location. For example, these are the mutation examples of what mutation causes what type of problems there is when it comes to the production of CFTR protein. So some have production problem where no protein is being produced. That means the gene does not produce the CFTR protein at all. Some have traffic problem where the CFTR genes are not being sent to the cell surface. Some have some impaired in the regulation of the protein where the protein are not able to be transported out. Some have a decrease in the transportation of the protein to the surface. Some produce less protein. Some mutation causes a less protein production, and some produces a less stable cell surface, so the protein are not able to be efficiently transported out. So based on this mutation that we have identified, we can now give the correct treatment according to what was needed by the patient. After the CFTR gene screening, we can divide the patient with CF according to the mutation classes. So additionally, in each class, we can perform the direct treatment according to the graph that I've shown you earlier. So this is a group of people with the normal mutation of CFTR. We call it the class 2 mutation. So these people would benefit from the normal type of treatment. But there are other classes of mutation that we've seen just now, and they need different type of therapeutic strategy that can be used. So instead of them not benefiting from therapy that was given to this group of people, they can benefit from other type of treatment that will help the condition get better. Of course, there are issues that comes with personalized medicine as well, and I think the biggest ethical, legal, and social implication to personalized medicine can be divided into 2 points. The first one being an increased amount of health information, and the second one is the excavation of existing disparities in healthcare. So in health information, traditionally, the sole possession of healthcare providers increasingly is also the possession of individuals in the form of their personal health records. And also there's also the third party who obtain this um, authorization to use the data that was given. So first of all, individuals may suffer from embarrassment, stigma, discrimination, and other harm in to their dignity when sensitive information is appropriately disclosed. So the question of privacy, like who gets to hold your record and who gets to um, use your information. And secondly, the quality of healthcare may be compromised due to individuals who fear improper disclosure of their sensitive information. So when people have this very sensitive information about you, for example, your genetic predisposition to a certain type of disease like Alzheimer, for example, or are you predisposed to getting Huntington's disease, for example, will you be discriminated against when it comes to insurance policy that you're about to buy or something like that? And there's also a public concern of harm to individuals who may have info predisposition or risk of getting certain types of mental disease when it comes to them trying to apply for a job, for example. And in the case of liability, like who's responsible to hold on to this record? And there are a movement that is going on these days where people are fighting to allow individuals to hold on to their own health record, and they are able to control who gets their information by, uh, selling their data, for example, to people who wants to buy this personalized information. I mean, for example, if you do the 23andMe test, your data is out there in public domain, and you're not able to control who gets a hold of that data anymore. And this is a concern of ethical and also legal issues. And that leads us to the excavation of existing disparities in healthcare. Genetic test panel, for example, is designed using data from one population group mostly and may not capture the genetic variants relevant to disease risk or treatment response of other groups. We are not properly represented in the global data of genetic variants. We may have other variants that may lead us to a certain diagnosis, but we don't know about it because we are, the minority, and we do not have enough genetic testing done yet to our own population. The cost would also be a problem. A certain set of group may have an advantage economically when it comes to getting access to this healthcare, and that would cause a reduce in benefit for patients who are derived from that care. And this characteristic is common to many new healthcare technologies. So if patients are unable to access this new technology, then they are also unable to enjoy the benefit of personalized medicine. So however, the centrality of these technologies to personalized medicine also reflects the growing interest in empowering patients to monitor their own health, to perform research on their own health of their own health problem, and make positive health behavior changes. In this way, personalized medicine reflects more general trend in healthcare to encourage patients to use information technology in order to take responsibility of their own health needs. So I believe I overshot my timing. I'm sorry, but I would like to end today's talk by quoting that medical science cannot really exist without biochemistry. And in all places where great science was done, there was a critical nucleus of people, each working in their own research area, but at the same time, we're all working together in a collaborative and a synergetic way. So maybe if we work together, all discipline of science and medical, especially, maybe we can together push um, healthcare to the next level, and yeah, bring healthcare to the new personalized medicine era. Thank you.
Thank you, Dr. Fazlin, for a very enlightening and insightful talk. I believe there are many questions in the chat box, but due to interest of time, maybe you can answer the first one, and the rest of it you can answer in text.
Okay, so the first one is, what is the readiness of Malaysia healthcare towards personalized medicine besides cancer therapy, and what stage are we in now? Right now, I have to be honest that we're not that ready. For example, the busiest hospital that we have in the country, HKL, is still paper-based. It's really difficult to get information of a patient if it's still, you still have to dig into the files and to find out results. So we can't add on the information to that. But I have to say that the government is doing quite a good job these days by having the MySejahtera as where you can keep your medical records. So that is a step forward for all of us, I think. And we also have the academic world that, for example, IMMP, UMBI, and also I Promise, that works very aggressively in doing research and finding more information about the Malaysian society, especially, and what biomarker work for us, and what do we need to know about our own society and how we can handle the healthcare. And I think all these components need to go together in order for it to work. And we're at the beginning, we're at the starting line, but I think with a lot of dedication and help from all all sides, we will be able to make it.
Thank you so much for the answer. I think you can continue in the Q&A box. And
Sure.
For the participants, please rate our talk today from the polls at your screen. And Dr. Fazlin, nice having you around.
Thank
maybe
you.
we can have a longer chat in the next conference.
Yep.
Okay, thanks everybody. And you shall, after answering the polls, you can leave to the next webinar. The next speaker is ready.
Okay, bye.
Right.